sticking around. I know the first part, like I said, was intense from a monastic standpoint. And then this part, we're going to get into a little bit of clinicals. So one question I wanted to just mention, if you're wondering so far, it's like, hey man, this sounds like if somebody's like really depressed, you're going to tell them to read the Psalms. If that's what it sounds like so far, you're right, because we're only part one. Okay? Remember, we're going to talk about this in depth. So we will talk about a spiritual intervention, clinical intervention, all kinds. All four domains of biological, psychological, social, and spiritual. We just want to start with spiritual, because I don't know, it's a Christian conference, whatever. They make you do it. It's part of the rules in the Bible. So that's, just as a heads up, so that you don't feel too antsy. But we're going to get into this stuff now. Okay, so then follow to the Holy Spirit. Amen? So our aim for this section, what are we going to talk about? We're going to classify depression. We're going to look at sadness versus pathological or clinical depression. Okay? Because, like we were talking in the workshop, anybody here been sad before? If you haven't, just let me know what's your secret. You just every day is amazing. Maybe we should talk for a different reason. Right? Normal sadness, like we know, sometimes maybe it hasn't been, like you said, like a little, I don't know why I got so caught up in the Friends thing. It hasn't been your day, week, or month, or even your year, right? It's that's how it goes, right? And sometimes it's stress or exhaustion or illness, any of these things. Oh my gosh, a long drive to Boston. Somebody was coming from New York and it took them 8 hours. Shouldn't take that long. That can make you kind of sad, okay? Or an illness, or we were talking in the workshop, oh man, my patients are stressing me out. Well, maybe that's making you sad, but that's the same thing as depression. And some of this can sound intuitive, like, oh my gosh, come on, this is basic. We all know this kind of stuff. You'd be surprised. Sometimes we get consults in the hospital, and it's like, psych consult, patient cried. Okay, that's kind of making me cry now. Because why would you think that's like a DSM criteria for anything? So if it sounds like it's sort of basic, again, people in multiple specialties may not know. Yes?
What do you define as sadness?
What do I find as sadness? That's a good question. Any thoughts? What is sadness? Anyone want to throw like an emoji out there? Right. Yeah? Feeling unhappy. Yeah, so you can think of it that way in terms of the opposites, right? The opposite of happiness. Sometimes, essentially, right, it's an emotional state where you are not at your best, where you feel down, or you're disappointed, or you might cry. There might be physical manifestations of sadness that might present in tears. But intuitively, we sort of get what sadness looks like. When somebody's down, or sad, or unhappy, we've seen that before, maybe once or twice. Maybe we've even experienced it in the mirror here or there. So we get that part, but the question for us sometimes is, what's the difference? Because we understand the idea of, I didn't do well in an exam, I got sad. Somebody didn't give me a proper whatever, I got sad. But we don't really know, okay, how much of that now is to the point where somebody's telling me in one of these little things in between, I went through a tough breakup, and now I'm sad. Or I went through a breakup and now she's sad. I'm having a great time. It can go either. And a side note, actually, when somebody, one of the things they tell us, I'll just tell you real quick, is sometimes when somebody describes a particular event in their life, they say, oh, I just lost my job. And you say, oh my God, I'm so sorry. You say, no, I hate my job. So it's the best thing that happened to me. I'm so glad they fired me, so I don't have to, whatever. Anyway, sadness. It can happen for no reason at all, sort of like we saw from even the monastic literature. It can be related to a spiritual problem, right? Again, this is the lip that we talked about. Is there sadness that is spiritual in nature? Yes, we talked about some examples. Could there be things that are not really spiritual that make you sad? Yes. And like we talked about, I alluded to the spiritual problem criteria in the DSM. Which is kind of cool, at least that they recognize that there's something spiritual out there that can cause people some distress. So that's going to be the bulk of our discussion. Here's the distinction from regular sadness or regular depression. And the tough thing I feel in this discussion is the words are the same. So because the words are the same, they overlap and the meaning gets lost in between. But here's the difference. We're talking about pathological depression. We're talking about a specific criteria. Why does that matter? Is that over a long, long period of time, things were proposed and say, okay, does pathological depression, does it have this? Okay, let's study it, let's do a research project, let's do a big trial, and then say, okay, no, it has to include this. Because if you have this, then it really means that that's a part of it. So there's specific criteria, and that criteria has come along in a long way after a lot of study, okay? It's diagnosed by a professional, or it should be. It's got several causes that we'll talk about in some detail. And it can be, again, independent of a spiritual problem, or, here's the kicker, it can overlap. You know, we talk about in medicine of comorbidities. Like, can you have diabetes and hypertension? That would be really strange. Like, nobody has that. Can you have spiritual lip, despondency, despair, and clinical depression? Can you have both at the same time? Ooh, what? You guys are getting advanced training here, yes.
Are they two separate things?
This is what I'm trying to tell you, is in fact, they definitely contribute to each other, right? There's overlap. And if one is not well controlled, we're going to use the kind of comorbidity language, it can make the other one worse. But they are definitely distinct. They're distinct because sometimes, and I've seen this personally in patients, you can have someone with clinical depression, and that's gotten better, but the symptoms or the manifestations of the spiritual problem weren't properly addressed. So now their PHQ-9 is better. You know, the number that we use to measure progress of depression. You were this number, now you're this number. Fabulous. But spiritually, you're in the same place in terms of how you view God, how you think God views you. And as a side note, that part of how you view God, how God views you, has physical implications in your life. I'm not getting into it, it's not pertinent for us here, but they've studied actually, if you believe God is punishing you, you can have an increased mortality after surgery, for example. It's wild. Does that make sense? So they're distinct elements, they can overlap, but we want to at least break down now the clinical piece. And we're going to break it down first by this, is that this is a costly issue. I don't know if you can read this well. Okay, yes. $80 billion problem, or 25 million Americans being diagnosed with this or suffering from it. Leading cause of disability worldwide. And the reason why I think this is important is when we think of, again, like severity, like, oh, depressed, having a bad day. Imagine being completely disabled by something. In the physical sense of the word, like, I have some pretty bad knee pain. Because of all my basketball days of just dunking on people just day in and day out. I was giving them business, I couldn't help myself. Okay? I can have some knee pain, but I can be disabled because both my knees are bad. There's a distinction there, right? Is that I can't do what I'm supposed to do because I'm disabled by something. It never for me ceases to be important to underscore this point of how this can actually put a halt on your life. That life stops because of how depression can impact you. And a quick note on, I don't know if you can see all the things in this slide, but how depression impacts your body, your physical body. Because it turns out, here's a weird thing, is that your brain has some impact on the rest of your body. It's weird. I don't know how. It seems to do something up there. Like it's connected to your head, it's connected to your neck, and it's news to me. So because of that, it's no surprise that there is an increased risk of a heart attack or cardiovascular disease. It's no surprise there is a significant decrease in your immune system. It's no surprise that there is memory impairment, cognition, focus, etc. Pain. We talked about substance use and pain in the workshop. Like these clear physical manifestations that, like, okay, if you're a healthcare provider, if you're a doctor, pharmacist, whatever, right? And someone comes to you, like I'll give you an example. Somebody came to me after a heart attack. She was 52, and she was on 9 different meds to optimize her care. You know, blood thinner this, hypertension this, something for her toes, like all this kind of stuff. Like tickling medicine, all kinds of things, right? How many meds was she taking when she saw me? No. What do you think? 2? 2. I said 2, 10. She added another one, okay. Mike's thinking 0. 15? 0. She wasn't taking anything. She just had a heart attack. I was like, lady, you're gonna die. She's like, what kind of doctor are you? It's like, a good one. I'm trying to save your life. But she was really depressed. And she's like, I'm so depressed, I can't get myself to take lisinopril, whatever, So now this gets in the middle of your medical care because you're too depressed to get good medical care. And we see this now both, again, in our patients, in our families, in people that we know, but there is a direct impact on your physical health. Cool? Okay. I wanted to run through the physical and then get into what it does in your mind. Now that I'm thinking about it, I should have put this section afterwards, but too late. Let me give you a couple of snapshots of what the mind becomes, or thoughts that kind of lead us into depressed ways of thinking in these little infographics. This idea of magnification and minimization. Have you ever had this? I think they've studied this before, or you can tell me. If you ask somebody, hey, how was my lecture? They can tell you 10 great things. Wow, you have a great clicker. The projector was just fire, it was like HD. Tell you 10 great things, and then one bad thing. Which one are you going to remember? The bad thing. We tend sometimes, so in some sense, the things that I'm going to talk about, we all sort of do this. But in a person with depression, they do this a lot. Almost in a predominant, constant, daily sense, because the mind begins to see the world differently. Is that now, any positive thing will be minimized, any negative thing will be magnified. You could be a star athlete. People tell you you got money, you got fame, you got this, and this. Minimize all that stuff. Yo, you're not emotional though. What? Talking about specific players. You know what I mean? So this is what happens, that we all sort of do it, but then it gets done more as the mind begins to go distraught. I've had this experience all the time. So this morning, I almost didn't get a donut. Later, somebody put me on hold for 3 minutes. Then I got a paper cut. My job is unbearable. Have you ever gotten a paper cut? It's very traumatic. Okay, it's very difficult. Don't judge me. Personalization. This is again something that happens and it becomes a way of life for a person whose mind begins to go this route. Is that things become, you have a tendency to blame everything that goes wrong in your life, and you internalize this. You internalize it. As opposed to saying, who else could have played a role in this situation? Does this make sense so far? Okay? Again, do we tend to sort of do this sometimes? It's like, the workshop didn't go so well. It's because I have the inability to speak to other people, and it's all my fault. And people don't like me. And I internalize it and personalize the issue. As opposed to maybe, people are gassing, and it's like Sunday afternoon. There's a lot of beans in that burrito, or whatever we had in that wrap. Right? It was a very interesting lunch. Just keep it real. Mad love, but still. Okay? Emotional reasoning. This is another thing, again, we sometimes do, but then you fixate and only do it sometimes if you begin to have this experience of pathological depression. Is there a difference between feelings and facts? They begin with the same letter. Right? Sometimes, though, I feel X, meaning this is my reality. This is my truth. My emotional reasoning is the way that my decisions will be made. And the counterpoint can be, well, what evidence is there for me to make the decision based on this feeling? Is there a fact to combat this feeling? Mental filtering. This is another one, okay? This tendency to focus on the negative. It's similar to minimizing and maximizing, but it's a distinct version where now you're seeing 100 things that could go really well, but somehow you find the fault in it, and you are finding that fault in it. Not somebody else is minimizing or maximizing it for you, but you tend to find a way to zero in on one thing and make that the central focus, and you filter it out, and it becomes the thing that you see and you focus on. Make sense? I'm going to run through these. These are just misconceptions or kind of errors in the way we think. Shoulds and musts. This is, in our culture, in Egyptian culture, there's some elements of guilt. I don't know if you've experienced this. Like, you should do this, you must do that. The expectation of course, like, you can be any career you want, any specialty in medicine. Feel free to pick anything you want. You can pick anything in healthcare and it'll be totally acceptable. We love you. You should do this, and you must do that. To have these unrealistic and unreasonable demands for yourself. Sometimes when I talk to patients who have this weight, this crumbling weight that they've put like 5 tons on each side, of what the expectation is of my day, my performance, my ability, socially, academically, and you wonder if you have this kind of weight on you, is there any other way to do that? Is there any other way to approach this besides have an unrealistic expectation of your own life? Sometimes we crumble under the weight of our own pressure. And again, if it sounds like something that you've done before, it's helpful to reevaluate the weight that we've placed on ourselves. Black and white thinking. This happens as well. We're done with the mic? That's so black and white. Bean's gonna help. Wow, just in the nick of time. So we'll continue for now. You can hear me okay so far, right? Okay. So black or white thinking is sometimes not understanding the subtlety of things. It's like, oh, how was this retreat? It was the greatest retreat in the world. How was my job? Oh, my job is the worst thing in the world. I should stay at retreats forever. I should be a professional retreater. It'd be a nice gig. Semana for life. This is my favorite, catastrophizing. When you're a person whose mind begins to see the world differently. Again, imagine, there are some people who see the world in like rose-colored glasses. And it's like, oh, we got pulled over. That's okay. Cops are nice people. It's like, oh, it's snowing outside. Oh my, it's a winter wonderland. People are so annoying, right? Like, you don't want to be around those positive people. No, I'm just kidding. It's nice to have those people. But sometimes, if your brain begins to now enter into a pattern of depression, you have now found a way in every opportunity to find the most catastrophic possible solution. We got pulled over, okay? We're going to prison. Alcatraz, here we come, right? Oh my God, I got a bad grade on exam. Thank you so much. The mic stopped working. Oh man, so the building is gonna collapse. You know what I'm saying? And it sounds almost facetious, but like, you can catch yourself in that line of thinking. And if that's how your mind is thinking all day, imagine how exhausting this is everything that happens, you see the most extreme way of how this can be a disaster. Small setback, musiba. Small setback, explosion. And then that also leads to, here I go jumping into conclusions. Right? So people laugh and it's like, yo, this is my life. So it's Tuesday, Wednesday, this is all I do. We understand what this means, is that sometimes we see a possible explanation, or we can think 15 steps ahead of this is what it really means. Again, we all do this sometimes, but the person who is dealing with depression does this way more frequently. Overgeneralizing is another pretty good one. The tendency to make kind of broad statements about everything, okay, is that, again, like I said, the workshop thing, people just don't like me. But how? You're Coptic and you're wonderful and you're a man member. People everywhere loves you. Oh, people just, da-da-da. Generalization of one kind or another. You make blanket statements that try to fit everything. Make sense so far? I wanted to run these through real quick. What do we do about these thinking errors? The scripture tells us that we can be transformed by the renewal of our mind. There are ways for us to combat this, essentially that we talk back. The other verse that was important too was that we bring every thought into captivity. We talked about being pulled over and the cops. Imagine, again, like we talked about in the beginning, that you're setting a guard over your heart from the Psalms. You set a guard over your lips, a guard over your heart, and you say, the thoughts that come, I can examine them, and they don't have to just roam free in my mind. Not everything can just have free reign, free entrance, but rather, I can examine them and I can talk back to them. There's a beautiful book, actually, it's called Talking Back, and it has some scriptural references as well as something from the church fathers, also from Evagrius, on how we can ask ourselves what evidence is there for this, what would someone else say in the situation, etc. Like different ways that we can examine the validity of that thought or feeling to see whether or not there is veracity to it. And I know we mentioned Elijah, and I wanted to mention this before we get into the criteria for depression, is the basic needs. We said the first patristic, one of the patristic quotes that we had in the first session of how God is saying, or how the church father is saying to us, take care of your body as if you're going to be around forever, but also to live as if you're going to die tomorrow. In that story, there were things that were highlighted that I thought was really important. Nutrition. Anybody here a nutritionist? We need more competent nutritionists. Even though, I mean, our diet is phenomenal. I think oil and grease are just the #1 ingredients in everything we eat. But there was nutrition part because this has an important factor, an important element in depression, in the way we think. That the angel even gave Elijah food. There's a sleep part, which, like I said, sometimes the most godly thing you can do is take a nap. God let him sleep. There's an exercise part. They went for a stroll. The angel of the Lord took Elijah for a walk, essentially. And there's quiet time. God gave him, the angel took him to a quiet cave and sometimes let him process what was going on after he had the situation of, God, kill me, life is not worth living. These are stress management techniques. It's fire. Interesting. Eat, sleep, eat, sleep. Questions so far in terms of what depression does to your mind, what depression does to your body, and what the general impact is on depression? Good so far? Yes. Oh, yes, Marianne first.
All right. With the mind distortions, some of them sound similar to what I've heard about with anxiety. Maybe maybe I'm incorrect. Is that so? And if so, why is that?
Good question. So yes, if they sound similar to how anxiety can also distort the way you think, it's true. There is an overlap because in depression you can have major depressive disorder and you can have anxious symptoms in there, or you can have an anxiety kind of manifestation. It's almost like, we think of it this way, there's sort of different, and we'll get into this as well, and when we kind of classify different kinds of depression, there's different flavors of depression and how it shows up in different people. For some people, you can have more of an anxious depression, where you're depressed, but also because you're so sad and you're so down, and you have these cycles of distortions, that makes you kind of worried and anxious about the fact that you're so depressed. So the cycle kind of continues in that way. It's debilitating in the same way because it continues that way. Versus you can have a different kind of depression where there's really no anxiety to it at all, but it's more so like neurovegetative. Like I can't get myself to be motivated, I can't really do anything. So I don't have all those distortions. I don't catastrophize, but maybe I just do, magnification and minimization. That's like my big distortion. So I want to give you just a sense of what distortions are, but you don't have to have all of them, and sometimes you will see some of them in other disorders for sure, especially anxiety, as well as things like PTSD. You can have a bunch of these as well, but certainly these are things that can be seen in depression. Yes?
So taking the anxiety question on a step further, can you have an anxiety, is it kind of flipped? Can you have 80% anxiety and 20% depression the way you said? You can have 80% depression, 20% anxiety. Is that a thing? Or?
It's a thing. It's not so much quantifiable in that sense of saying, what percentage of anxiety is it versus what depression. We do think about it in terms of like primary and secondary for the sake of, just kind of prioritizing, and also for the sake of treatment, it has implications. Because there's some medications that totally work for both things. There's some medications that are really helpful for depression and can make anxiety worse. So you don't want to use the wrong thing when there's both of them there. But it's actually pretty frequent that they would be comorbid. They would be coming together. For some patients, though, one is kind of more predominant and one is secondary. For others, it's the other way around. But we don't use exact percentages. It's a very good question. Mike, you had a question. You did? Yes.
I have a question. I might have a longer answer, but do you think that there are some cases in which medication isn't always the answer in psychotherapy, just talking it through is a better step?
Never. I'm just kidding.
It's like, okay.
That's a nice question. Always take meds. Always. No, actually, statistically speaking, and also in life experience, there's more people who are being treated through anxiety or depression through therapy. And as we'll get into, therapy has so many different domains, different kinds of therapies, different modalities, different skill sets. So absolutely, there are many, many, many people who do not necessarily need medication. And sometimes, but the important thing for us, like in the mental health world, is that we're always working collaboratively together. Somebody's in therapy, that's great. They may or may not need to shrink. And there are some patients that I see, even as a psychiatrist, I don't prescribe them anything.
Yeah.
I just do therapy. And now I have the prescribing power.
I just feel like everybody's on sertraline.
Right.
It increases
Right.
suicide, all these things, so I was just
Yes.
wondering.
Well, you know what? Actually, let me comment on that real quick, even though the med thing is later. Do you guys hear a point? It's an important one. Everybody's on sertraline. I was in a conference, so part of the work that I do, I didn't introduce myself fully, again, by the way. I'm a psychiatrist. Part of what I do is direct patient care in private practice. Part of what I do is more academic stuff in Columbia. And part of what I do is something called collaborative care, because there just aren't enough psychiatrists. So we meet with different specialties, OBGYN, surgery, primary care, say, hey, let's treat this because they're not all gonna come to see some weirdo shrink. Sometimes in those conversations, we have the same question of, I was advising or I was having a conversation with someone in OBGYN and saying, hey, we need to treat this person. So I can't give them an antidepressant. They'll kill themselves. Say, I'm sure. Where'd you get that from? Right? So understand, and we can get into it more, but there are some risks and benefits of every medication, and to understand that there is, for depression specifically, there is a risk of untreated depression, and there is a risk of any medication that you give. Sometimes we think about a risk of a side effect and say, because of the side effect, I will not treat you. In reality, when you're looking at where that black box warning came from, of 10,000 people, nobody actually died by suicide. Nobody. There's an increased ideation in a specific amount of people between the age of 16 and 24. So for us, it's important, the education piece. This is a little bit more nuanced, but hey, you guys are a sophisticated crowd, so I figured I would tell you. Okay? So when you're having a discussion about black box warnings of medications, is there a risk? Yes. Is there a risk of taking a medication versus no medication? Absolutely. There is no riskless approach here. Sometimes we have that misconception. And then to understand that if somebody is taking a medication with close monitoring and close follow-up, they do very well. Whether it's sertraline or Prozac or whatever else. Yes?
I hope we don't go down the rabbit hole like medication, but just a quick question, like can some patients get dependent on it?
Good question. And people often ask that question, that like, okay, I'm not going to take this now for the rest of my life, and I'm going to be dependent and addicted. Depends on the medication we're talking about. We're talking about things like for depression, SSRIs, sertraline, fluoxetine, things like that. No, you don't become dependent. For many, many patients that I see, you start on medicine, we reevaluate you in 8 to 12 months. For some patients, you're doing much better in a different life situation, and we come off the medication. Gradually, slowly, so it's comfortable, but it's not a physiologic dependence the same way that it would be, for example, for like a benzodiazepine. Somebody's taking Klonopin, and that's an addiction. It's a physiologic dependence that it becomes, it can still be done. We taper people off of this all the time, but it takes more time and more effort and more caution. So the question is, are these medications addictive or do you get dependent on them? No. Can they be reevaluated after a certain time? Maybe continue, maybe not continue? Absolutely. Does that answer the question? It's good? Okay. Let me actually skip this part. This is a part about listening. I'm gonna just skip this part too. Here's what we need to get to. What if you're doing all these things, right? Like we were talking in the break. What if you recognize some of the thought misconceptions and you're still depressed, and now we're getting to the point of we gotta get help? Let's classify what we're talking about. We're talking about actual depression, okay? We're talking about first the fact that it impairs function. Like we talked in the workshop, this one that has all those Ds. There's a timing factor of it of over 2 weeks. There's a function part of it that it impairs, that you can't do the things that you need to do. Sometimes what it looks like in kids or younger people, sometimes see like teenagers, is different the way that it would in an adult. Or even in like parents. Sometimes, let me give you an example. You can think about somebody who's like our parents' age, and they're just really irritable. There's like this underlying irritability all the time. All the time. Whether they're watching ART or a heavy TV, that's just irritability all the time. The news or not the news, they're home or they're away. So it looks a little bit different depending on different age groups, but there is a timing factor, an impairment factor to it, and the fact that it's present nearly all day, every day. That's a big hallmark for it as well. Okay? Here are some things that we might see specifically when we're talking about now clinical depression versus, we talked about just sadness. What's different? You might begin to see weight changes, not just around Christmas time, where it dips a little bit, and then now, makes some changes. Weight loss or weight gain, so there's changes there. Sleep becomes an issue. How many people here have sleep problems? Nobody? Okay, cool, just me. I'm just so sleepy right now. Wish I could take a nap. But if you begin to see that there is a pattern of insomnia or hypersomnia, somebody who can't sleep at all, or sleeping through every class, sleeping through work, it's an issue, hypersomnia. Or they get to sleep, you can't stay asleep. Another part is that when we talk about how this can impact cognition, focus, memory, psychomotor, agitation, like they're agitated or irritable, kind of all the time on edge. It seems like something is just kind of not right in that regard. Energy. Like this sounds, again, it's sort of intuitive, but when you put them all together, you see the big pattern. You know what I'm saying? A lot of us can have a little piece of, you know what, I have no energy today. A lot of us can have a little piece of like, oh, I couldn't sleep last night, so I don't have no energy today. It's a long weekend, staying up all night, eating Chinese food, and it's hard. But when you see here the energy piece, the concentration, as well as, very importantly, the recurrent possible thoughts of suicide. That suicide piece is another big, dangerous clue that you might be in the middle of a major depressive episode. So we talk about the episode, and we talk about the disorder. The fact that you need one or more episodes to have a disorder. And we'll talk about medications here for a second. Is that sometimes you could be in the middle of an episode, and you could be treated with wraparound services, medication, therapy, nutrition, a nap, a hug, the Psalms, everything. You can recover from that episode. You can do better, and you can maintain some of those same resources and take away some. And one of the things that you might take away is medication. Does that make sense so far in terms of the basic criteria? This is probably not foreign to us, we've seen this somewhere along the line, right? DSM-ish sort of thing. And we talked about this too of being the leading cause of disability worldwide. This is the part that I wanted to share with you though about subtypes, or how it can be a little bit distinct. There's major depression in general, but you can have another kind of subtype of persistent depressive disorder where somebody doesn't look quite as acutely depressed. This is the kind of person who you might see in your church. I've seen people who are Coptic who come to me and say I don't know, for the past 5 years, I haven't enjoyed anything. Nothing? Nothing. Wow. But you've been able to get to work? Yeah, I do the work thing, do the school thing. I provide, what one parent told me. My job right now is I'm a wallet. I'm are you a nice wallet? Are you a Gucci wallet? Or are you just a basic wallet? He's like, yeah, that's what I am, I'm a wallet. My kids just look at me and say, money. My wife, she ignores me. I'm like, get used to that. Just kidding. The police is standing right in front. You better watch what you say. It's on camera. But there's that. If somebody that you see that has more of a chronic situation, it's not as acute, but it's been going on for a while. Sometimes it can be, this is scary, but this happens as well. In some severe cases, people can actually get psychotic symptoms. And we've seen this a lot as well, so we're aware of kind of how it can present. You can also get, we were talking about before, postpartum depression. And one of the dudes, I won't call him out, was a typical dude. He was like, man, having a kid is not the most happy time of a person's life. Why would they be depressed? I'm like, my man, just please don't ever talk again. Because you will be murdered. Okay? Tell me what it was like the last time you had a baby. Just talk about the process. He's like, well, I don't know. It was, I don't mean to make fun of him. I remember where he was. But you see what I'm saying? So postpartum depression is very real. And the FDA had a new medication that's, of course approved, but it's unaffordable for everybody to actually take. But it's a very serious and vulnerable time in a person's life when you're having a baby. So it's an important thing for us to be aware of in the peripartum, postpartum period, for us to kind of be on the lookout for that. As well as seasonal. We're in Boston, Northeast. There are a lot of people who just get these symptoms, the severity of them really hit them in the winter. It's a really, really tough time. And the way you treat this can be different. The way you approach it and understand it can be different. We're not going to get into bipolar depression quite as much, but the thing for us that's worth knowing is that people who have bipolar depression spend most of the time in the depressed phase. They're just depressed the whole time, and every once in a while, they're just the best servant in church. They do all of the things. It's like, wow, how did you plan all the retreats of the year this morning? So be aware of that. Make sense so far? Any questions on criteria? And how this is, like the severity of it, the timing of it is different from the day-to-day sadness. Oh, another question that somebody asked that I think is important to mention is, what about bereavement? Like we talked about if somebody loses somebody, right? If I have a family member, about to shut, right, and we lose them, and I'm grieving through the process, could I still have a major depressive episode? What do you guys think? Some yes? Yes, very good. That's the right answer. That's the example. Right? If there used to be a thing called the bereavement exclusion. It's like, no. You know, if somebody's going through a tough time, come on, shrinks. Don't like make everything a disorder. You a bunch of weirdos. You want to make everything a disease. Like, no. If you're going through a tough time, it's understandable. But if you're going through a tough time, and it now begins to meet this criteria, where you can't function, you can't get to work, you can't sleep, you can't eat, are we just going to say, nah, it doesn't really count because you're grieving? No, we're going to say you're grieving. We want to support you. We don't want to judge you. We don't want to label you. We want to support you. We want to give you more and more help. This is especially pertinent in our culture. Because when we have someone who is grieving the loss of a spouse or a terrible tragedy of like grieving the loss of a kid or things like that, we want to be able to give them all the support that they can have in that moment. And not just say, oh, it doesn't really count. I know a priest that we've talked about before, who like when he goes to tragedy situations, he's packing pills. Like a boona. Your medical license is in question here, my man. You can't just be walking around giving people bentos. It's like a little Ativan, never heard about it. So that's that. Questions about that so far? Good? Okay. I'm going to skip this, because this is basic epidemiology stuff. But this part I want to highlight. Of where does this come from? Where does this come from? Because people are always asking, like, okay, at the end of the day, and we as healthcare people, like, what's the root cause of this? And the root cause is all these things. This is a really good infographic, I felt. There is a genetic component to this. When you study people through genealogy is a biblical word. When you study people hereditary factors, it's there. The brain chemistry piece is there too. Sometimes, and again, even though we're healthcare people, I find myself having this discussion with people in healthcare of trying to convince them that no, depression is a thing. It's a thing in the brain. Like, yeah. It's a thing, but like, not really. Okay. So sometimes, like we said, nutrition, physical health, you guys know. Anybody here in primary care? Some people, right? So there's some primary care stuff that can give you depressive symptoms, right? Hormones, thyroid, cortisol, all that kind of stuff. Right? Physical, drugs, stress, these are all things that can contribute. And getting into some detail without diving into it so much, but these theories of like growth hormone or cortisol or thyroid are all things that need to be kind of worked up beforehand. This kind of goes without saying, but I'll say it, is that one of the things that happen when people see us is if they haven't been worked up for a physical cause of depression, we go through that process. I've seen patients who, like, oh, I'm super depressed, but I'm also like really cold, and I'm also this and that, right? No, you just need some symptoms, and you'll be okay. You're fine, you're not depressed. So that's an important piece for us to think about too. And sometimes the question of that, like, oh, did you get lab work done before you go see your therapist? Is an important one to have for us as healthcare people and servants of the church. And like we said, norepinephrine concerns home. Genetics, like we said, there's a link there for sure of, throughout generations, children of depressed parents. There's epigenetics. We're learning more and more about this part of that. You can have, because somebody asked me this in the hallway too, a lot of conversations happen in the hallway for some reason. It's the nature of this hotel, I guess. Somebody said, hey, like, okay, so if I have like the genes to be depressed, خلاص هعمل ايه? I'm like, I don't know, تعمل ايه? It's like if you have the genes to be predisposed to alcohol use, shots for everybody. What are you going to do? Take some shots. That's not quite the way it is, right? There's some things that we're predisposed to. Like we're all Egyptian, we're predisposed probably to be a little chubby. Doesn't mean that you have to be, right? You're predisposed to be socially awkward. It's just the reality of our nature, okay? It doesn't mean that you have to be, okay? And one of the same things here with substance use as well as depression, you could be predisposed, but your predisposition or your epigenetics can be changed by your life choices. Some things can turn on a gene or turn off a gene. This is what we're learning now. Okay? So that's important for us to know. Stressful events and family interactions, we talk about Egyptian parenting, which is just amazing. There's no end to the amazingness of that. Adverse childhood experience or trauma. I know we don't talk a lot about the word trauma because, like we were talking in the workshop, is that we like have spiritualized trauma for it to be like, you know this face? This is the face of it. But trauma is not always a super spiritual, I'll take it, crowns of glory sort of situation. Okay, there are many situations where we need to stand up to trauma the same way that the Lord Jesus, when he was struck, he was like, yo, what you doing? If I said something evil, bear witness of it. If not, watch your hands. For I uncreate them. I don't know if you would say that, he's too nice. But you know, he did kind of make a decisive stand against it. Make sense so far? Cool? Alright. We'll probably go for another 10 or 15, and then that'll be the end of it for us. There's a ton of slides. I'm going to try to run through some things that are not quite as relevant, but I wanted to mention some things about the heavy topic, but it's an important one, of suicide, when things become life-threatening. Suicide is on the rise in general, and we have an opportunity in the faith community to put a dent in that, okay? Over the past couple of decades, it's been rising more and more. It's been increasing. Some risk factors, if somebody's obviously tried this before. And sometimes when I talk about this topic, I think like, even again, I do this from time to time. I talk about these things. But I'm surprised that we can have people among us, I don't know why I'm surprised, but like people who have really struggled with this thought before. And people in your church at this point, I promise you, there's been someone in your church who's either had this thought or maybe has got to the point of attempting to take their life. So the prevalence of it is there. I'm going to run through a couple of these things because they're sort of intuitive. Because there's one part that I want to focus on for the sake of time. Is myths about suicide. I want to talk about some myths that we need to change. Here's one. A myth or a misconception is that if somebody really wants to hurt themselves or take their life, they're going to just find a way to do it. There is nothing you can do to change that decision. Wrong. Thankfully, this is wrong. Or sorry, this is the next myth. This one is people who talk about it won't do it. Like if you really were serious about it, you would just keep it DL and surprise everybody. Not the case. Sometimes somebody who's talking about it, this is like an ongoing internal dialogue that people are struggling with. And every once in a while they'll put out a feeler to people around them and say, what's going to be the reaction? Is it going to be positive? Is it going to be negative? Does anybody care? I wasn't around anymore. So for us, we got to take this idea of any possible mention of something like this is an opportunity for us to intervene. The people who talk about it can actually fall victim to it. The second one is what I was talking about before, is somebody who really wants to be able to find a way. That's not true either. Thankfully, we found in research is that if you're able to take a small step to take somebody's ability or means away, like put a little delay in it, to make it a little harder to actually get this done, that goes a long way. It really, really helps. Sometimes it's an impulsive decision, and if you can stand in the way of the impulse, you make a big difference. Means reduction, like we talked about. Okay. This is a big one too that's coming more in society now from like a medical ethics perspective. People in Europe, you could be a teenager now with depression and decide that it's time for me to get physician-assisted suicide in some places. I think for us, morally, we take a different stance on that as Christians in healthcare for different reasons. But the idea this is sort of a personal decision or a personal choice, this has generational impact and community impact on, like when St. Paul tells us that when one part of the body hurts, the whole body hurts, and they're just like, oh, I don't care, it's my lung. I have the other one. It's not quite as we know. This is a big one. Has anybody heard this before? Right? Like if you ask about it, you're going to put it in their mind, and you're going to like mind control them into doing it. Before you asking about it, they would have never imagined it. They just never heard the term. You said, lamb. Really? But I understand. I mean, I make light of things because I make light of everything, or I try to, because it's kind of a dark topic. So, research though has shown us this is not the case. When you have a direct question and you call out the idea in someone's life, you're not putting the thought in their mind. You're sometimes, either this is something that's super far from their mind, they're like, dude, we talking about? No, I would never think about that. That's it. Next question. You want pizza? Like vegan pizza? I mean, there's glazes around here. Like, or it is a thought in their head, and now they feel relieved because the internal dialogue, that again, they're Coptic. Let's assume that you're talking with someone who's Coptic. The shame and the weight of the stigma of saying that I would ever think to be Judas. I would never say that to somebody else. But you asked me? No. Maybe I trust you. Maybe you get it. Or even if you don't fully get it, maybe you sort of get it. Or maybe you pretend to get it. Maybe you went to a conference. You know what I mean? Like, this has saved people's lives. Your role, your conversation. And maybe this leads me to one important thing. Sometimes we think, in this whole subject, we can't make an impact because we forget that the idea of caring for people is a team thing. You know a team? Anybody here play any team sport? Like chess? Right? If you play any team sport, the whole idea of a team is that multiple people are important. There are things that I grant you that I can do that maybe you can't do. But there are many things that I can never do and only you can do in the life of the person that you know. Right? We sort of get that. And in psych especially, one thing that we think about, we have a nice table with the treatment team, and everybody's equal. The parent, the therapist, the shrink, the person who's just doing like activities just for no reason, the activity therapist. So you guys understand that you're part of the team, whether or not you are a mental health professional. Wherever your healthcare background is, or even non-healthcare, it's a big impact. Make sense? Okay. So that's the part that I want to tell you about that. Is that you're not, the research is very, very clear, it's unequivocal, you're not putting the thought in people's mind. Unless you're like that weird case that was, I think it was in Boston, of the girl who told her boyfriend, like, oh, go commit suicide. Or go, go kill yourself. So don't do that. Just a disclaimer. Okay? Just in case somebody was wondering if that was a good idea. Make sense? Here's an important thing too. What are some warning signs? What are some things that we want to think about? Like, oh, this can kind of tip me on that something is not right. Sometimes people just throw out these little statements. Maybe it's a Facebook post. Maybe it's a casual conversation they're saying here and there. Isolating, like we talked about, breaking off from the body of Christ. A change in hygiene. I know, again, we're Egyptian, so this is relative. Sometimes you walk into church and there's like a must. Yeah, this is very spiritual. So if there's a change from that, Chanel number 5 that we usually smell in church, it's like this is a special aroma, heavenly aroma, okay? Then you want to think about it. This is a big one. There was just a big story about, like of all people, like construction workers and suicide prevention in that world, and how there was this really powerful story of they gave away his personal tool of a thing, like how they do construction. And he gave it to his friend. He's like, oh, just hold on to this and I'm going to see you tomorrow. And he died by suicide. And they were saying this sparked a big movement in the world of construction. To say, guys, we give away this stuff. It's a big deal. And let's really think about prevention. And then suicide went way down in the construction world after this intervention. Something to think about. Somebody starts giving things away, it's a warning sign. Sudden change in mood is an important one. here are some things too, this is important, with the idea of like putting the thought in people's minds. But sometimes, if as a community, things that can make us more vulnerable, if there's things in the news or we hear about someone, like I was speaking with a church a few years ago where they had a young person die by suicide in their church, and they were really cognizant, they were aware, like this makes our congregation now more vulnerable in this period. I said, yes, you're right. Let's do something different, let's put something in place here. Hopefully though, we don't wait until that happens to be proactive. That's why we're here, that's why we're doing this. But when it does happen, we want to be aware of the implications of that. Sometimes it's loss or grief. What we saw in New York is after the time of like Anthony Bourdain and Kate Spade, that had an impact locally because they were such cultural icons that it made people think about something that they might not have thought otherwise. Cultural and religious beliefs are an important thing that in the literature, it can go one of two ways, right? What you believe about suicide can be very protective or can be very potentially destructive. So for some people, if they believe, you know what, if I die, then I'll come back, things will be better, then that would be more not helpful to kind of think about. For us, I'll tell you kind of for me, just personally, I've been conflicted about this because on the one hand, when we think for our belief system that like suicide is the worst thing ever, like don't ever do it, there's potential eternal, implications, that's sort of a deterrent for people, and it's good in that sense. Say, hey, make sure you know that, this is a deterrent. But on the flip side of that, we gotta be cognizant when we're dealing with families who have lost someone to this, to be able to say, hey, like, let's put this in context for a second here. You know what I mean? So that we don't, like, further traumatize families who've been through a trauma. Does that make sense? It's a fine line, and I'm just telling you, like, honestly, I don't have a way to, like, magically fix it, but it's something that we as a community, I think, have to think about. Can keep it a deterrent and saying, yes, suicide is not good, for spiritual reasons, but also be able to comfort families. Make sense? Okay. Yes.
Question for you.
Yes, please.
So, has there ever been any talk between so I know that some clergy will not perform. So in terms of like the mental health professionals in our Coptic world, has there ever been a discussion about like, let's see this as like a mental health issue, and if somebody died from heart disease, we would have a funeral for them. You know what I mean? Like, I'm a therapist,
Yes.
so I'm on the
Yes.
same page as you.
Yes.
But has there ever been like a conversation, at least in the, in our neck of the woods, of like, let's treat this differently?
So yes, but there's not enough of that conversation. I know there's been a conversation, and we were talking a little bit with Emma Gillis yesterday of like, where is the global Coptic conversation on this? We should be on the same page. And he was reminding me of the reality that we are not in a global Coptic anything. Like each diocese does whatever they feel is appropriate, in some ways, right? So I can tell you for the New York, New England, Emma David, for example, is a big proponent of this and really gets it in the proper way. That he will make sure that no, if this happens, there's a trauma involved, we're there for the family, we're praying the funeral, we're pouring our hearts out to God, and we're really being present. None of this stuff of like making things much worse by not praying the funeral. Like that, it kills me, and I'm gonna be honest again, like, I'm not pulling punches on this. That's wild. It's like inappropriate and damaging and destructive, and I don't care what priest sees me talking about it. Like, we gotta say, these are some of the things that we need to stand up to and be able to say, no, this is wrong, Abuna, you can't do that. You gotta pray the funeral. I'm gonna snitch on you, I'm gonna call the bishop. If the bishop doesn't do it, I'm gonna call the Pope. Like, when you escalate to HR, can I talk to your manager? Like, you gotta go up the ranks because like I said, I've seen both things happen. I've seen like a wonderful, empathic, supportive response. I can at least speak for New York, New England, and Emma David, because he was instrumental in this whole mental health thing. He sat everybody down 7 years ago and was like, guys, we've got a crisis in the church, and sometimes we don't know how to deal with it, and sometimes we as clergy are not equipped. I was like, wow, Sayed has a vision. You know what I mean? And I'm not saying this because he's our boss, I'm saying just for real, honestly. But there are some places that are not doing that. And if that's not the case, we gotta be able to have a firm leg to stand on and say, as the healthcare community, maybe talk to Samantha. Maybe come and say, hey, Samantha, help us, back us up. We gotta have a tough conversation. Because some of these things are going to take a tough conversation. In the same way that when we hear, like when I hear of somebody, let's not say priests, that we pick on them too much. Again, the disclaimer is the overwhelming majority of priests are doing a great job, trying really hard, they're being there for their families and their churches, like they're really great. It took a while for me to appreciate that until my friends got ordained. Like, yo, this life's tough. But for servants even, when I hear a servant come and say, like, oh, we don't believe in this, oh, then we're going toe to toe. Then we're doing the same thing that St. Paul said to St. Peter, like, I will confront you to your face and to your mom. Like, we're going. The your mama thing is added for dramatization. But you know what I'm saying? Like, we can't be afraid to confront things that are not going right in the church, especially when we are bringing or restoring the correct way that things ought to be. We're not adding something new. So thank you for raising that question. Other thoughts on this real quick? How you guys feeling? You feeling tired? You want to stop? You keep going? Okay. If you need to take a breather or something, feel free to do it. I want to try to just finish some other things to make sure that we cover them. As you would figure, substance use is a big risk factor. Access to me, this is big. Some people that came to this and are here, like Southern people, like in New York, nobody has a gun. I tried to bring like I didn't try to bring it, but you lose it. Never mind. It's hard to get weapons. I was remembering a song where you say you try to bring like a plastic pellet gun and you go to prison. Like, you can't. Right? There's different laws in different areas of the country. In the South, sometimes it's easier to have things for collection or the access to whatever weapon you can have. Sometimes I counsel patients on where prescription drugs are in your home and how readily available that is to you. Right? That's a big conversation for us to have. And sometimes the unwillingness to be able to get treatment can be a big barrier too. Some protective factors that we want to think about. Connection to family, and family can be also part of the church. These are things that are just displayed in literature. Sometimes pregnancy and responsibility for children is a very helpful thing, so we should just make people get pregnant. Sometimes there's affiliation. I'm sorry, too many jokes. The pregnancy thing is a tough one. Religious affiliation is a good thing in general. The literature is telling us that the more affiliated you are, the more present you are is a good thing. Work or school, being responsible for that is also helpful. So now we're going to jump into the treatment phase. Are you still with me for a few minutes? Still alive? Give it a good stretch. Okay, we're going distance. We're going treatment. What I want to tell you big picture first is that there is a whole lot of stuff that we can do for depression. We're not just talking about meds, like my friend said in the beginning here. Oh, put everybody on this medicine. We're not just talking about one thing of therapy. There's ECT, TMS, all kinds of new meds that have came out. So it's an exciting time to be able to treat this stuff. We're going to start with the basic thing of meds, pharmacological things, antidepressants. These are selective serotonin reuptake inhibitors. You guys are healthcare people, so you've heard this before, but what are the big barriers that we think about when we are prescribing people? I was speaking with a therapist recently who oftentimes when we talk about medications, we're all very collaborative, we're all on the same team, but one therapist was like, I don't know, I think medication make everything worse. Or one infectious disease specialist that I saw was counseling him on treating a patient. They were like, I don't know, antidepressants scare me. I said, so do your meds. Your meds scare me a lot. I can't pronounce any of them. Striblend, anybody hear an ID? They're just really complicated HIV meds. Anyway, sometimes our fear about meds, like, I don't know if you ever do this, you ask a really good question in your head, and you figure, this is a good question. Like, are medications more dangerous, than we think they are? That's a good question. And you just go with it. You don't actually ask somebody out loud like we did here in the proper context, and you don't get the proper answer, so we don't wind up actually addressing the fear that we have around our medicine. Does that make sense? So kind of, sort of? All right. Some examples. So this is another class that's not usually used anymore. It's sort of older. Same with this one, an older one. Reasons why people stop these meds. Oftentimes, someone will say to me, I tried a medicine, my stomach hurt, I stopped the medicine. But you have a doctor, we could have done something different before you stop the medicine. Okay? So for us as well, as we're talking about friends or family or patients, it's like, hey, if you try a medicine, before stopping it, have a conversation. Is there anything else that I could have done? Is there a different dose? Is there a different kind? Or I tried it and it gave me a side effect, whatever the side effect was. Same thing, right? So our role in the community, right? We talked about there could be the other role. Oh, you tried this medicine? Medicine's the worst. Stop taking medicine. Sometimes that happens in the church. Or we can be that other reaffirming voice of saying, no. If somebody thought that you needed medicine, that's a good thought. Don't make a decision otherwise on your own. Make sense so far? These are some examples of meds. I didn't want to go through individual medications for the sake of time and for the sake of the fact that you can just like Google them. But anybody have questions about specific antidepressants for any reason? Either like a reservation about them or concerns? Yes?
With fluoxetine, a lot of patients have been experiencing either somnolence or like sleepiness or like wakefulness. So when would be the best time to take it and like just stuff like that?
Yeah, good question. And I've seen patients who have experienced either side. Right? So that's part of why it's an art, and it's part of why in continuous conversation with the patient, it can sound a little simplistic maybe, but if a patient is taking a medicine that's making them more sleepy, take it at night. Patient is taking a medicine, and for some reason you have a different reaction. The general reaction to fluoxetine is it gives a little bit of a kick. So usually we have people take it in the morning, but some people react differently to it, so take it at night. The general thing though, if it's making you a little bit activated, take it in the morning. But that's the thing with all these medications, is that you can make little tweaks on what time of the day you take it, and how you take it with food or without. And that can make a big difference for you. Instead of stopping it, but you can make adjustments. Does that make sense? Any other questions on the specifics of meds? Yes?
Do SSRIs cause damage to your brain?
Good question. It's a really good question. Do SSRIs cause damage to your brain? So, SSRIs have been around since the early 70s. We've got great data long term. And here are the two things that I'll tell you. Does untreated depression cause damage to your body and your brain? A little quiz, a little other infographic that we have. Right? Yes. Does treatment of depression with an antidepressant like fluoxetine cause damage to your brain long term? No. We have long-term data on safety and efficacy of these medications, and in comparison, especially to untreated depression for a long time, and the hazards and risks of that overall, right? So sometimes, like I'll get a patient who will tell me, oh, but I read in like Glamour or something that all these medications are dangerous. I love Glamour, it's my favorite magazine, but I don't know if they're right on this issue. So that's the thing, is that sometimes there's these pop culture kind of things that are not really evidence-based, not really like sound. Say something wild to kind of get, there was recently an article in, might have been the New Yorker or something, that was talking about how like, when you try to get off these medications, it's like a nightmare, it's the worst thing in the world. I've never seen it. It happens. It's so infrequent that they made it seem like it was the standard. So the direct answer to the question is no. But the flip side of untreated depression is actually damaging to your brain and your body. Cool so far? Okay. I'm going to run through this part as well, but I want you to know that there are other kinds of second line medications. Sometimes you can use stimulants, sometimes you can use a medicine like this one, pramipexole. Depending on the nature. The reason I tell you this is not to know which meds are what, but to know at least, you know what, someone tried a medicine that didn't work. There's so many kind of adjunct treatments, so many other side treatments that you can use that can help. Sometimes even herbal medications, not herbal medications, herbal supplements, like St. John's Wort. The APA did put a little thing that says that, you know, that the evidence is modest, but, you know, in the spirit of like holistic medicine, there's a role for it a little bit. St. John's Wort. I don't recommend it because the evidence is not there. Then there's newer stuff. There was a party drug that now has like been turned into a miracle drug of ketamine. It's an anesthetic, and it was used as a party drug, But now it's been very effective. They've seen emerging research that you can use it IV as well as now it's an inhaled version. Again, no like plug for any kind of drug company, but it's a new therapy that's been very effective. So that's another kind of option for rapid results. Well, that's the other thing is people sometimes ask how long does this stuff take to be effective. It takes a few weeks, but sometimes in an acute setting, you can use a medicine that works within days rather than within weeks. Another kind of medicine that also was just like a psychedelic drug of use, but now has a lot of potential for use in depression, is psilocybin. I'm going to run through these part real quickly, just stop me if you need me to stop. Then besides meds, I was talking with one of the med students in the break about this thing called ECT. Anybody ever hear of ECT? Anybody hear anything positive about ECT? Anybody here have like fears of ECT? Like, oh, I don't know if I would recommend this to anybody. It sounds like it's terrible, right? Real talk. So what this is essentially, you're inducing a seizure in a controlled environment, and it's the most effective treatment still that we're seeing for depression. It is unbelievable when you have over like 80% response rate in some of these times, where people who are like suicidal get way better. But let me show you the picture. But it looks super scary, especially the boxers. I mean, like, what's does everyone have to wear these Christmas boxers? Like Santa Claus getting treated for ECT. So it looks scary, and because of movies and stuff, like from way back, our patients who remember like One Flew Over the Cuckoo's Nest and things like that it was like shock therapy and patients are like getting traumatized and tortured. But the reality is it's very safe. There is a side effect potentially of mild memory loss, like you get a little confused, but it's very effective, very safe, and it's also very anticlimactic. If you see it happening, you're expecting something to happen, and like patients like finger goes like this, and like that's it. Oh, we're done here. Wow, this was cool. I'm so glad I signed up to take this elective. Going to lunch. So it doesn't look like anything. It doesn't look like anything fancy, but what is really effective. So why this is important is because if you mention it to somebody, and again, we're going off like the options of treatment. People usually get scared of it, and it sounds intimidating, but it's very effective and something that we should be aware of. When should we be aware of it? Is if you need a rapid response or failure to drugs, or if there's been a good response in the past, or if it's your preference, or there's a high risk for suicide. Okay? Or also if you don't want to use medications because of other kind of medical contraindications. Another thing is TMS. Let me show you a picture of it first before I tell you about the picture. I just have the video. No, I do have the picture. So it looks like this. You're basically it's like a really cool hat. It's going to be cool, everybody's going to be walking around with a TMS machine. No, it's not really a hat. So something that is these brain waves, essentially, that are targeting, they're targeted impulses. What they're doing, instead of ECT, instead of that route of like needing IV anesthesia, and you need like a whole surgical setup, you have a targeted way of directly looking into one particular part of the brain and targeting with these waves. Let me show you if I put it out here. So it's non-invasive, and it's called transcranial or transmagnetic stimulation. And through these short impulses, basically these magnetic impulses, they target specific limbic structures. I haven't used it myself, but there's a lot of emerging literature, and for people who are not responding well to meds, not responding well to therapy, and you can use this. But I've worked with someone who uses it, and his whole clinic is just TMS, and people who did not respond to anything responded really well to TMS. Oftentimes it's used for treatment-resistant depression. Make sense so far? This is one of my favorites, because you can get this from like Amazon for like $10. For people who have just seasonal depression, around this time of the year, you can get something, basically like a UV lamp that you use for half an hour a day, and it's really effective. It's been studied, been really helpful for patients who have this seasonal kind of depression. And you can combine it with therapy and medication, or you can just use it in and of itself, and there's really good data there. So it's incentive to get your tan on. All right? So that's treatments that are medicine, non-medicine, or second-line medicine, ECT, TMS, all kinds of fanciness. Any questions on there before I tell you some cool therapy examples, modalities? Yes?
Now, how about the whole movement of the mindfulness, the yogas, the whole Far Eastern meditation, gratitude, cleaning the chakras?
Yes, yes. So it's a great question. I'll tell you two things. One, so a lot of mindfulness apps, stuff we had a recent discussion with a guy from Harvard who studies all these mental health apps. There's over 10,000 apps right now in the App Store who all talk about like mindfulness and I want to help you do yoga, so like stand like this, whatever. And what they've shown is, unfortunately, they are very effective at taking people's money. It's highly effective at that. But they're not effective at actually helping people. Only 1.9% of them have any real evidence base to show that they have any relevant impact. But they're very popular, very useful. So it's not my crusade, I'm not going to fight against these apps. But the idea of mindfulness and yoga and these other kind of therapy-like modalities is a good thing to do. And it's something that we do recommend, and it's sort of in line with what we're going to talk about now in terms of different therapy approaches. Because usually, like I said in the beginning, when we think about therapy, we just think about one thing, but the reality is it's very broad, you know, and there's a lot of things to discuss within the realm of therapy there. So that's my thought on mindfulness and yoga. No problem. Other thoughts, other questions on the treatment, the non-therapy treatment so far? Cool? Okay. We'll wrap up with a couple of these things that I'll just mention to you because they're cool and they're different. So there's one thing called positive psychology. I don't know if you've heard of this kind of emerging field. There are these positive psychology interventions. They're kind of specific therapies. One of them could be, or not could be, but is dignity therapy. One of them is gratitude therapy. The cool thing here, I love this because it was like things that we know are good for you from like a Christian perspective. Like, is it good to have gratitude? No. Gratitude is the worst. Of course it's good. Is it good to forgive people? Of course. But is there a way to do it systematically, as if you're going to prescribe a new intervention? Yes. That's what's dope. So here, things like dignity therapy, or I was speaking with a guy in Memorial Sloan Kettering who developed a therapy called meaning, like basically a way to find meaning in where you are. Meaning-centered therapy, I think was the term. It's got a lot of traction based on the work of a guy named Viktor Frankl, who was a psychiatrist in the Holocaust, wrote a really great book, Right Man's Search for Meaning. Really recommend it. So, forgiveness promotion therapy. This is another really cool kind of therapy. So I'm just going to run through some of these examples just so you know them. So dignity therapy, gratitude therapy, forgiveness promotion therapy, loving kindness and compassion meditation is a kind of specific focus on like enlightening empathy and how to manage the stress in like an interpersonal setting. Spiritually informed psychotherapy, which can include like pastoral psychotherapy. There's a really nice book by a lady named Michelle something, Christian CBT, Christian Cognitive Behavioral Therapy, that I really enjoyed. Forgiveness therapy. Did you know, and I was sharing this with somebody before we started, that there are randomized controlled trials, which is like our high standard of evidence. We have our research in the back here, right? With forgiveness therapy, right? This is a way that you can remain chronically angry around people that, like we know this, you can hold on to these negative feelings, or you can find a way to go through forgiveness, and there's a specific model that they go through. It's beautiful. The REACH model. It's a process. So it's an acronym that tells you this. You can recall the hurt, you can begin to develop empathy, you look at an altruistic gift for the offender, you have a commitment to forgive, and you hold on to forgiveness, and then they measure this later on. It was super cool when I first heard this. Actually, the person that told me about it was somebody here in Dana-Farber too. So this is running it real quick. The fact that there is a systemized way to do it. So depending on the people that we're talking about, like, oh, you're somebody, you know, part of what's really holding you back is trauma and how to deal with it. So maybe part of it is trauma-focused therapy, maybe part of it is forgiveness therapy. That will be really helpful for you to think about. Out of GW is this idea of how to instill hope. So we talk about all these basic Christian virtues, hope, love, faith, or bond, like all these things. And there's a systematic way that they were able to get into it. Behavioral activation, less so, it's pretty common. Just basically saying that your behavior, like instead of waiting to feel motivated to do something, first do something and allow that to motivate you. It's sort of the spiel behind it. Problem solving therapy that's focused on problems. Sounds kind of intuitive. This is the mainstream one, so everybody knows about cognitive behavioral therapy, which is essentially, therapists can tell us in the room, is that your thoughts determine your actions, and if you can change your thoughts, which is sort of what we believe about metanoia, right? That's what we believe about repentance. That if you can change your mind, you change your behavior, you change your patterns, you change your life. Family therapy, familiar with the concept. Group therapy, running through these if you want me to stop, please tell me. Interpersonal therapy, play therapy, psychodynamic psychotherapy. Learn too many stress management tools. Help me. Okay. That joke. Actually, we'll run through this. We'll run through this. Some quick do's and don'ts is when we are speaking with people who are struggling with this, we want to be empathic, not judgmental. We want to share the responsibility, like share the presence, right? We are a healing presence. That's sort of what we believe as Orthodox people. What you don't want to do, and you can use some humor where it's appropriate. Like don't do it as I do it. I do too much humor. People tell me that all the time. I say, I'm sorry, I can't help it. My brain thinks in one way. People ask me this sometimes, you know what? I want to be vulnerable, I want to be in the community, but I know people are Coptic. If I say I'm dealing with depression, they're going to go to, can you believe that person's depressed? So we want to try to not do that. Or name call or generalize. The big thing though, maybe I will share with you this week. I know I sort of skipped it. There was one part earlier about listening, which basically begins with the fact that like, in our empathic listening, don't worry about first like trying to offer solutions. We want to be present, want to hear, want to ask questions more than we say advice. People oftentimes when they come to us are not immediately looking for advice, they're looking for a validating presence. They want to know that you love them and you are there for them. Okay? So that's a big takeaway. So I know with that, this is long, thank you for your patience. Questions on anything. So as a recap, we talked about the patristic perspective, we talked about where the Desert Fathers talk about despondency, despair, all that kind of stuff. We talked about what sadness looks like, we talked about some what clinical depression looks like, what the criteria is, the different plethora of options of medications, different plethora of options of therapies, and as well as what spiritual interventions we can put in. And the big model, I forgot the slide, but in the workshop, as you remember, there was one diagram that I showed you that has the biological, the psychological, the spiritual, and the social as one thing together. For us, our role in the healthcare world, like what I do all day in training was tell people spirituality impacts psychiatry. So I'm gonna do a research project on it, I'm gonna do grand rounds on it, I'm gonna just be in the voice in your ear that says there's over 3,000 peer-reviewed articles that say spirituality has a big impact, so we must always ask about it. In whatever field you're in, this applies to you. This applies to this standard of care that I will always ask my patients about their spiritual life. It's a must, it's good practice. I would never, like, I don't know, not ask about allergies or something. Right? You have to, it's good practice. Not because you're a Christian, it's good practice, because you're a clinician. So there's that for us in the work world. And then our role in the church world, same way that Dr. Story was saying, is to bring that clinical world into the church world and say, this stuff is real, this stuff is a thing, and we can do it, and it does not diminish the truth of church. Just because somebody is in therapy doesn't mean they can't talk to Abuna anymore. You're allowed to have both. Just because somebody's on a medicine doesn't mean that they are no longer eligible for communion. It's not contraindicated. Make sense? It's a lot of stuff. I'm so grateful for the fact that you're still here after the super long weekend. I can't remember if I put my contact in here somewhere. In case you have, yes. I email, phone number. Feel free to reach out if you have questions that you think of later when like the somnolence leaves and you're not as sleepy. I can share with you the slides as well. Feel free to like use them. They're not like all mine. I stole them from somebody else. So I won't just steal things. So feel free on that end. So, but with that, I think if there are no burning questions, any other burning questions for the moment? If not, I'll be around. Feel free to approach me. But again, thank you so much. And maybe actually, let's end with a quick prayer. Can we stand up for a quick prayer? Lord, we got it. In the name of the Father, and the Son, and the Holy Spirit. Our Heavenly Savior, we thank you, Lord, so much for giving us your body and blood today, Lord. Thank you for giving us the medicine of immortality. Thank you, Lord, for putting in our hearts the desire to care for your sons and your daughters, Lord. Your children you've entrusted in our hearts and our lives. Our patients, Lord, who are a gift, like we were learning this weekend, Lord. Give us, Lord, the insight, the eyes, Lord, of yours that we can see that we should do a metania before we see a patient, because they are a blessing, and they are a privilege, and they are your personal presence in our lives, Lord. Give us the ability to have patience and courage and wisdom and love when we're dealing with people, Lord, who are struggling around us. Give us, God, the conviction to share this with our churches, that nobody is suffering in silence anymore in my parish, and nobody will be able to go in my area, in my community, and not know that there is healing, there's help that involves both our faith as well as our clinical judgment, Lord. I'm so thankful, God, for my brothers and sisters who are here, who after a long weekend will still come and take notes and pour themselves out in front of you and say, Lord, use us. Use us to bring healing. Use us to bring restoration of individuals and families. We need you, Lord. We know that you are our ultimate therapist, our ultimate doctor, our ultimate bishop of our hearts and souls, we pray and live for, Lord. You are the source of all our healing. We pray, God, that you can heal our brokenness, our hurts, Lord, our pain, our trauma, that you would allow us to be able to seek help from you, seek help from your church, seek help from your hospital, that we can, Lord, be continuing to be renewed and be refreshed and be people who are continually growing in your love. I pray a blessing for our brothers and sisters here. They have safe travels back home, and that their spirits are renewed, and that your Holy Spirit fills them and equips them thoroughly for every good work that you started in their lives. Lord, pray these things in prayers of St. Paul, St. Peter, with the blessing of this beautiful fast, and in the intercession of our Mother St. Mary. Hear us, Lord, as we pray, our Father, who art in heaven, hallowed be thy name. Thy kingdom come. Thank you guys so much.
Thank you.
Thanks for being here. Yeah.
Testing that can be used to identify